Hi there, my highly valued, treasured, and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you all to sit back and spare me part of your very precious time to share with you some useful tips which may prove very handy in your line of duty. So I welcome you all to part 1 or 2 of our pharmacotherapy MCQ series, which majors in infectious diseases. Welcome. Our first question reads, your infectious diseases clinical team is treating Mrs. TYP, a 66-year-old female patient, for suspected bacterial meningitis with double beta-lactam therapy using ampicillin and ceftriaxone. A resident inquires about the use of these two medications and whether one of them should be discontinued or stopped immediately to avoid therapeutic duplication. My question to you is, what is the rationale for using ampicillin plus ceftriaxone in Mrs. TYP's case? Is it coverage for drug-resistant S. pneumo? Is it true that this is therapeutic duplication and we should discontinue ampicillin? Or is it true that empiric meningitis therapy for patients older than 50 years should involve ampicillin co-administered with ceftriaxone? Or is it true that there are synergistic effects when the two are co-administered in cases where there is Staphylococcus aureus as the pathogen? I'll give you 10 seconds to choose the correct answer. C is the correct answer. For patients above the age of 50, there is rationale to co-administer the two. According to guidelines, there is need for additional coverage with ampicillin since such patients are prone to Diphtheria monocytogenes infection. Now, in immunocompromised patients with suspected bacterial meningitis, the potential causative pathogens should be expanded beyond typical pathogens. Just as a by the way, and we should consider evaluating such patients for Cryptococcus, Toxoplasmosis, and even nosocomial pathogens. But for this particular case, ampicillin and ceftriaxone are co-administered because of the fear of listeria playing a part in that age bracket. Now, if traumatic brain injury patients are being treated, then those with basilar skull fractures may develop meningitis, and the empiric management requires coverage for group A beta hemolytic streptococcus or streptococci, but doesn't require modification to treatment, i.e. vancomycin and ceftriaxone can serve the purpose. Now, in patients below the age of 2 years, ampicillin plus aminoglycosides is the recommended regimen. You can also choose to use ampicillin alongside cefotaxime in such patients. Let's move to the next question, please. And it reads, Mr. DMK, a 35-year-old male patient with cellulitis, visits your infectious diseases clinic. The ID physician prescribes tedizolide, which is marketed as Civextro, for this gentleman. So my question to you is, which of the counseling points listed below would be the most appropriate for Mr. DMK? Would you advise him to take one tablet once daily for 10 days? Or one tablet once daily for 2 weeks? Or one tablet once daily for 6 days? Or would you recommend one tablet once daily for 1 week? I'll give you 10 seconds to choose the correct answer. I would counsel him to take one tablet once daily for 6 days. I'd like to remind you that tedizolide Civextro is an antibacterial agent from the class of oxazolidinones, which binds to the 50S subunit of the bacterial ribosome, resulting in inhibition of protein synthesis. It is indicated in adults for the treatment of acute bacterial skin and skin structure infections, which we normally abbreviate as ABSSSI, caused by susceptible bacteria. It should be taken once daily for 6 days without regard to meals. Let's move to the next question, please. And it reads, Mrs. LMC, an 82-year-old female patient, is admitted to your general medical ward with community-acquired pneumonia. She has a past medical history of hypertension, hyperlipidemia, and type 2 diabetes mellitus. She currently takes ramipril, atorvastatin, and metformin to manage her condition. And she has no known drug or food allergies. She hasn't received any antibiotics in the past half a year. So my question to you is, which of the beta-lactams listed below would be the most appropriate for her treatment now? Would it be meropenem, doripenem, etapenem, or imipenem cilastatin? I'll give you 10 seconds to choose the correct answer. I would settle for etapenem. Now, the IDSA CAP guidelines recommend a beta-lactam plus a macrolide for inpatients who aren't in the ICU. Now, etapenem is the only carbapenem recommended for patients described in this clinical scenario. I would just like to add that imipenem, cilastatin, and meropenem are reserved for patients with CAP in the ICU who are at risk of pneumonia due to Pseudomonas aeruginosa. Doripenem, on the other hand, isn't FDA approved for CAP and has had unfavorable results when it was studied for hospital-acquired pneumonia. So it would be an inferior choice. Just like to emphasize that doripenem was the first carbapenem to have an extended infusion dosing regimen in its FDA-approved prescribing information, but it doesn't work well for this particular patient. Then I would like to remind you that imipenem cilastatin isn't likely to be used by extended infusion due to its short stability at room temperature. But meropenem, on the other hand, can be comfortably infused continuously over 3 hours with very good clinical outcomes. Let's move to the next question, please. And it reads, Mrs. RMM, a 49-year-old female, is admitted to your med-surg ward with a mild to moderate intra-abdominal infection. She claims to be allergic to vancomycin, and the last time it was infused, she had flushing on her face. She is a depressed patient and she currently takes sertraline for that. So my question to you is, which of the bacterial agents listed below would be the most appropriate for Mrs. RMM's treatment? Would you opt to treat her intra-abdominal infection using ceftriaxone, ciprofloxacin, tigecycline, or would you settle for meropenem? I'll give you 10 seconds to choose the correct answer. I would choose tigecycline. I would like to start by saying that ceftriaxone and ciprofloxacin are options for mild to moderate intra-abdominal infections if they are administered with metronidazole. Now, meropenem should be reserved for patients with severe intra-abdominal infections, and in that case, therefore, tigecycline is the most appropriate option for Madam RMM. Let's move to the next question, please. And it reads, Mr. NTN, a 47-year-old male patient, presents to your accident and emergency department with chills, muscle weakness, and a temperature of 102.4 degrees Fahrenheit. He informs the physician taking his history that he had a gold cap put on his molar tooth 30 days ago. A systolic murmur is heard during his physical examination, and the echo reveals a moderate mitral valve regurgitation and a valvular vegetation. And the blood cultures grow Streptococcus viridans. Currently, he has a creatinine clearance of 84 milliliters per minute. So my question to you is, which of the treatment regimens listed below would be the most appropriate for Mr. NTN now? Would you choose to infuse nafcillin for 6 weeks, vancomycin for 4 weeks, or would you treat with gentamicin plus penicillin G or ceftriaxone for 2 weeks, or would you settle for aqueous crystalline penicillin G for 4 weeks? I'll give you 10 seconds to choose the most appropriate regimen. I would settle for gentamicin plus penicillin G or plus ceftriaxone for 2 weeks. Now the 2-week regimen of a single daily gentamicin dose plus penicillin G or ceftriaxone is reasonable for uncomplicated cases of infective endocarditis such as this one, which are caused by highly penicillin susceptible VGS or S. galolyticus in patients with low risk for adverse events caused by gentamicin therapy. Now, this 2-week regimen isn't recommended for patients with known extracardiac infection or for those with creatinine clearances below 20 mL per minute. So just watch out for those cautions. Let's move to the next question, please. And it reads, DFP, a 56-year-old lung cancer patient, regularly receives chemotherapy at your oncology clinic. He develops a systemic cytomegalovirus infection. Today, he has an ANC of 150. So my question to you is, which of the treatment options listed below would be the most appropriate for Mr. DFP? Would it be valganciclovir, ganciclovir, foscarnet, or acyclovir? I'll give you 10 seconds to choose the correct answer. This gentleman is clearly neutropenic, so I would settle for foscarnet. Foscarnet is the best option for Mr. DFP given his neutropenia. Now, both ganciclovir and valganciclovir are usually agents of choice, but they can both worsen Mr. DFP's neutropenia. Therefore, they are contraindicated when the ANC falls below 500 cells per mm cubed. Now, acyclovir isn't recommended for the treatment of CMV infection at all. You'll not find it in literature. So that makes answers A, B, and D wrong, and C is the correct answer. Let's move to the next question, please. And it reads, Master HKL, 7-year-old boy, reports to your pediatric accident and emergency department with ongoing and worsening right ear pain accompanied by high fevers. He has no known significant past medical history. He was last seen by the pediatrician 2 days ago, and he received a prescription for amoxicillin for otitis media management. He has intermittent nausea and vomiting, and the pediatrician is concerned for the potential resistance to amoxicillin. For the first 2 days of therapy, he was able to keep his medication down. Today, he is unable to retain oral medication due to vomiting. He doesn't look toxic, he is stable. So my question to you is, which of the options listed below would be the next best course of action in Master HKL's management? Would you opt to administer vancomycin and cefepime IV with hospital admission? Would you put him on augmentin co-amoxiclav orally at a dose of 90 milligrams per kilo in 2 divided doses? Or would you administer ceftriaxone IM once daily for 3 days? Or would you put him on cotrimoxazole twice daily orally for 1 week? I'll give you 10 seconds to choose the correct answer. So I would administer ceftriaxone IM once a day for 3 days. Now, this case indicated that HKL was already on the drug of choice for otitis media, which is amoxicillin, but isn't improving, and now he has nausea and vomiting, which implies that the patient should now be treated with parenteral therapy, which also gives consideration to possible resistance. Now, the next best treatment option, in my opinion, would be ceftriaxone, which will provide the patient 24 hours of treatment before the next dose is needed. I'd just like to mention that despite the nausea and vomiting, the case indicates that the patient has otherwise stable vital signs and doesn't have to be admitted to hospital. Now, if Master HKL had unstable or abnormal vital signs, or if he had failed to stop vomiting, then admission would have been warranted. Now, where there is concern for resistance to the initial treatment using amoxicillin or for the otitis media, or if such a patient were experiencing nausea and vomiting, ceftriaxone would be the next recommended treatment, as I've just said, assuming there are no allergies that the patient isn't below the age of 1 month because of obvious reasons. Now, if a patient isn't having nausea and vomiting, but there is concern for resistance, then co-amoxiclav augmentin would be a reasonable therapeutic option. That's just a by the way. Let's move to the next question, please. And it reads, which of the antiviral agents listed below isn't effective against both influenza types A and B? Is it zanamivir, marketed as Relenza? Is it oseltamivir, marketed as Tamiflu? Is it amantadine, marketed as Symetril? Or is it none of the above? I'll give you 10 seconds to choose the correct answer. The correct answer is amantadine or Symetril. Now I'd like to start by saying that amantadine, Symetril, and rimantadine, Flumadine, are only effective against influenza type A and not against type B. And I'd just like to add as a by the way that the neuraminidase inhibitors, oseltamivir and zanamivir, are effective against both strains of influenza virus. So that makes answers B and A wrong. Let's move to the next question, please. And it reads, BZO, a 66-year-old patient, was admitted for community-acquired pneumonia. So while still at the accident and emergency department, a urinary catheter was placed as part of an order set in your hospital. It has remained in situ throughout his 5-day hospital admission. BZO has had no urinary symptoms. He has been afebrile for the past 2 days. His most recent WBC is 9.4 times 10 power 3 per microliter. Early today, the nurse requested a urinalysis and urine culture, and it turned positive for yeast. So my question to you is, which of the treatment options listed below would be the most appropriate for Mr. BZO now? Would you choose to administer an idursulfan? Would you opt for amphotericin B lipid complex? Would you infuse fluconazole? Or would you choose to remove the catheter? I'll give you 10 seconds to choose the correct answer. So I would choose to remove the catheter. Remember, no treatment is required for candiduria in an asymptomatic patient according to the IDSA guidelines. Now, this case doesn't report any complaints or symptoms by the patient, nor does he have fever or elevated WBC, so he doesn't need any antifungal therapy. Let's move to the next question, please. And it reads, Mrs. JRM, a 24-year-old female, is rushed to your accident and emergency department with a stiff neck and extreme headaches. She has a body temperature of 102.4 degrees Fahrenheit. She has no known drug or food allergies. She has no known medical problems. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Mrs. JRM now. Would you choose to administer ampicillin plus cefotaxime plus vancomycin? Or would you administer ampicillin and vancomycin? Or would you treat her with ampicillin and cefotaxime? Or would you choose to treat her with cefotaxime and vancomycin? I'll give you 10 seconds to choose the correct regimen. I would treat this patient with cefotaxime and vancomycin. Now, until proven otherwise, this patient has clinical signs and symptoms concerning for meningitis, and empiric therapy should therefore be initiated after lumbar puncture is performed. Now, the IDSA guidelines for bacterial meningitis state that a third-generation cephalosporin plus vancomycin is the empiric regimen of choice for bacterial meningitis in a patient who is 1 month old to 50 years old. Ampicillin is only needed as part of an empiric regimen due to Listeria monocytogenes being a common pathogen for patients who are either below the age of 1 month or above the age of 50 years of age. Now, a vancomycin dosing regimen of 30 to 45 milligrams per kilo per day in 2 to 3 divided doses is recommended in patients with bacterial meningitis. Just remember that. Let's move to the next question, please. And the next question reads, SDL, a 64-year-old patient with a gram-positive anaerobic lung infection is admitted to your medical ward. The infectious diseases consultant on duty intends to initiate therapy with clindamycin for 10 days or more. As the clinical pharmacist specialist in the ID team, which of the following counseling points would you consider the most important to discuss with Mr. SDL and the matched clinical reasoning behind it? Would you counsel Mr. SDL that clindamycin may be associated with lower extremity edema, clinical reasoning being that it decreases GFR? Or would you counsel Mr. SDL that clindamycin may be associated with a watery diarrhea, the clinical reasoning being that it causes increased risks of Clostridioides difficile infection? Or would you counsel Mr. SDL that clindamycin may be associated with projectile vomiting, the clinical reasoning being that it causes strictures of the pylorus in the stomach? Or would you counsel Mr. SDL that clindamycin may be associated with significant shortness of breath in 50% of patients, with the clinical reasoning being that it causes bronchospasms of the airway? I'll give you 10 seconds to choose the correct answer. So B is the correct answer. Now, one of the most relevant side effects or complications of the use of clindamycin is the development of Clostridioides difficile colitis, which can also be called pseudomembranous colitis or C. difficile colitis. And it initially manifests itself in the form of watery diarrhea. Now, while patients don't necessarily have to be told these details, they should be counseled to contact their prescribing physician if this develops, as additional evaluation and treatment may be needed if it happens. Now, the most common treatments used for Clostridioides difficile colitis are oral vancomycin. You can also use metronidazole. Now, in severe cases, both of these agents may be used simultaneously with metronidazole being administered IV and vancomycin being administered as an oral suspension. Now, this is the only time vancomycin is administered orally, as it doesn't get absorbed into the body when administered orally. So there you have it, my highly valued and esteemed and treasured viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly remind you to give it a thumbs up, to like it, and to share it widely with your peers. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come, and I thank you all sincerely for viewing and for listening to me. I sincerely appreciate your partnership, your continued support, and your very kind collaboration, and I look forward to interacting with you all in the next video. Thank you very much.